is posterior polar cataracts with pre-existing PCRs. Well, these are the biggest challenge which one can come across when there is a pre-existing, PCR. So this was a young male around 32 years old, wherein the posterior polar cataract was there with a PCR. Now, what do we do with this? The most important thing is the site of incision. It should not be parallel. It should be at an angle to the axis of the posterior capsular defect. Side port incision should not be exaggerated. The rhexis, I am trying to make a rhexis, which is an oval rhexis. This oval rhexis will have the longer arm parallel to the incision and at 90° to the axis of the posterior capsule rupture. So the longer arm is parallel to the incision and I'm creating an oval rhexis. Now, what does this oval rhexis do? Well, it's a double rhexis, I call it. It gives the advantage of the large rhexis and it takes away, it gives the advantage of a small rhexis also.
Capsular back turbulence allows easy nuclear sculpting and division and trouble-free subincisional cortex removal. The short rhexis arm helps in keeping nuclear mass intact and helps in IOL capture without a tilt.
So now the next step. What is the next step? I am going to, since he was a young adult, I am going to do layer by layer separation of nucleus, central nuclear core, epinucleus, then further layer so that I have a shield. I am going in at different planes and at different places so that I'm able to create, you will see I'm creating different layer by layer in the soft cataract for that matter. So you can see multiple layers here. So these multiple layers, now I'm starting with the aspiration. It will be, I'm not using any CDE. I could have used the IA also, but I thought I'll go ahead. First of all, I'm trying to take out the central core. This central core helped me because the outer epinuclear core and different layers were giving a shield to the pre-existing posterior capsule defect which was there. So I was not exposed to the posterior capsule by any means. I was not rotating it. I was taking out. Now it was practically the second layer which was coming out. So this layer was coming out. Now once that was done, so I thought at this point of time, I will take out the outer layer from that area where there was no posterior capsule rupture or pre-existing one. So I'm trying to, by realigning the phaco tip, I'm trying to take it out. Always keep the chamber stable. The fluidics have to be on the lower side. Now, one option at this stage would have been, I should have used a bimanual, IA. But I'm acting smart now. Just see how I have retracted this. So this irrigation is at a higher, as it is an anterior level, and this is at the posterior level. The second trick which I will play is, I will use the epinuclear scaffold. When I use that, I will not expose the posterior capsule to any fluidics which will cause hydration of the vitreous and subsequent prolapse. So I am trying to dislodge the epinucleus from the, by dislodging the cortex, but I'm not pulling it out. So I'm continuing, doing it again. I will not aspirate it. I'll just dislodge it. At this point also, the fluidics are much away from the posterior capsule. I will dislodge it more. And once I have dislodged it, I'll still continue till the time I have dislodged all the epinucleus and cortex from the equatorial attachments. You will see the last one which I'm doing. No, there's still one more. I'm taking the shield of the epinucleus, and once I'm with it, the next part is, I'll aspirate it in one go. So you will see now I'm aspirating it in one go without much of anything going behind. I'm going to inflate the bag. Now, what is the next step? The next step is this capsular axis, this posterior capsular tear has to be rounded off. So in posterior polar cataracts, I somehow find that despite the fact that they are extending to the periphery, at times I'm able to round them off, because that gives me more security and that gives me an option whether I can put an IOL in the bag or not. So I'm going in from the second side now. And when I'm going in from the second side, yes, I've been able to round it off. Once that has been rounded it off, next is the decision making now. I feel for my this thing that he's a young man, I'm trying to ascertain by staining whether there is any vitreous. There was not any vitreous. So I decided I'll put a lens in the sulcus and do optic capture rather than, in a young adult trying to risk it. So you can see how it is there in the sulcus at this point of time. I will inflate it and then I'll, dial it in. And once it has been dialed, now I will do the optic capture. So once this optic capture is done, so without making, in this, the strategy is incision location, sizing and aligning of rexes, stable chamber, low fluidics, no exposure of fluidics to PCR, layer by layer separation of nucleus and epinucleus, strategic epinucleus and cortex